Vulnerable populations, limited English proficient communities. The population that I'm going to talk about in this presentation includes communities that are non-English speaking or have limited English proficiency, aka LEP, in the United States. Information will be provided in order to support the idea that those who do not speak English or those who have LEP are at risk for certain health problems. These specific groups of people are usually refugees or immigrants who have come to the States for one reason or another. Refugees are those who flee their country out of fear of being killed because of things like race, religion, nationality, or their stand on politics. They often come with nothing but the clothes on their backs and have lived through rough, difficult conditions. Although seeking refuge in a country may be a big relief, there are many barriers that refugees must overcome when transitioning and integrating into the States. Many experience racism, discrimination, and violence. They may also have come from traumatic experiences such as rape, sex trafficking, and becoming child brides, leading to PTSD. All of these factors, on top of having to learn a new language, can create challenges for refugees when integrating into school, causing problems down the road. Not having insurance in America has been deemed as an epidemic, which has yielded huge costs to American society, both financially and in terms of their health. Uninsured status raises the risk of having limited access to healthcare needs and poor quality of services provided. High rates of uninsured status is linked to immigrants, with immigrants having a higher rate than U.S.-born citizens. This is due to several factors, including their place of employment not offering health coverage, economic instability, and illegal immigration status. An important aspect that may explain the high uninsured rates among this population has to do with limited English proficiency. Recent studies have shown that LEP immigrants are far less likely than English proficient populations to have health insurance. This is due to a wide range of things, which we will get into later. Utah by itself has resettled over 15,000 refugees since 1995 and ranked 24th place in refugee arrivals. Latino and Asian immigrants are among the two largest immigrant groups residing in the United States. According to one study, approximately 1/10 of the U.S. population over the age of 5 are considered to have LEP. This means that they have limited abilities to read, write, speak, or comprehend English. The 2010 census reported over 25 million Americans having LEP, which equates to 9% of the U.S. population. Hispanics and Asians dominate this group, with Hispanics occupying 63% and Asians 21%. According to the Utah State Office of Education, there were 53,219 LEP students identified throughout the 2010 through 2011 school year. An article by Kimberly Scammon reports that the total LEP population in Utah as of 2016 amounted to 138,734. Okay, question 1. What Healthy People 2020 social determinants of health could present a barrier for this population? Access to healthcare services, culture, language/literacy, and social norms and attitudes can all possibly pose as barriers for refugees, immigrants, or in more general terms, persons that have limited English proficiency. Access to healthcare is a long-known and persistent issue that LEP populations face. About 40% of the LEP population are without insurance, which decreases their probability of them seeking certain care. One research study's main purpose was to find out whether English proficiency and geographic factors play a part in insurance status of older Latino and Asian immigrants in the U.S. The results of the study found that Latino immigrants with LEP are much more likely to be uninsured than those who are proficient in English. But Asians, however, who have LEP are actually less likely to be uninsured. One indicator on why a majority of Latino immigrants are uninsured is because those with LEP have a harder time obtaining information and understanding it appropriately about how to apply for insurance and what criteria is needed in order to be eligible. As stated earlier, refugees have many hurdles to overcome when coming to the States. Many of them experience racism, discrimination, and racial violence, which makes the integration process more difficult. Question 2 indicates specific concerns that disproportionately affect this population. There is a significant difference in education levels between Latinos, Asians, and those who are English proficient or speak English only. According to the study mentioned earlier, Latinos and Asians with LEP have lower education levels than those who are English proficient. The article mentioned that insured status was lower amongst Latinos and Asians in the South than in the West. That may be due to lower educational levels, income, and less culturally established healthcare systems and staff. Nathanson describes LEP individuals' economic status as being lower than average, which indicates a low probability of being able to afford healthcare needs. Even when they are able to access care, they usually have a difficult time understanding and navigating their way through the healthcare system due to the language barrier. Having an interpreter would help in these cases, but having that option is not always available. PTSD is a common problem among refugees who come from living in war zones. Studies in Iraqi refugees indicate high levels of PTSD as well as social, behavioral, and emotional difficulties. Refugee children are sometimes victims of rape, trafficking, abduction, and forced into the military at a young age. These traumatic experiences can lead to gaps in their education, either because of their schools being destroyed or due to their parents being killed and having to take on the role of caregiver in their household. Question 3, identify at least one root cause associated with health disparities within your population. Limited English proficient populations are at an increased risk for health disparities, with one of the main causes being because of difficulties related to language barrier and not understanding the healthcare system, leading to high rates of being uninsured. Question 4, evaluate the population based on Maslow's hierarchy of needs. Looking at Maslow's hierarchy of needs, I would say that the only tier that is not being met is safety. LEP populations might not be getting the full picture when it comes to their health and what is going on with their body because they simply don't understand what is being explained to them. Language barriers have been shown to decrease patient adherence, primary and preventive care, and limit patient comprehension. This increases their risk for medication errors and reactions. Okay, let's see. Is this population at a higher risk for communicable diseases or infections? If so, what can be done to decrease transmission? Since the Refugee Act of 1980 was created, there have been more than 2 million refugees that have come to the United States. This act was set forth so that refugees coming to the States would be required to have health screening within 30 days of arrival. The screening targets specific diseases that refugees are at risk for, including TB, hepatitis B, parasites, HIV/AIDS, STDs, anemia, diabetes, hypertension, cardiovascular disease, and lead poisoning. They also check for pregnancy status, immunizations, hearing acuity, mental health conditions. These risk factors seem to be present for refugees due to their unique situations of fleeing from their home countries, but does not seem to be caused from speaking another language or having limited English proficiency. Systemic health concerns and social inequities that have been around for a long time have put minority/ethnic groups at a higher risk of getting sick and resulting in fatalities due to COVID-19. Ethnic minority groups refer to people of color who come from a wide range of backgrounds. These groups of people have had to endure many unfair circumstances caused from social determinants of health. Social determinants are barriers that block certain groups of people from having fair opportunities related to healthcare and economics. The CDC points out several factors that put ethnic minority groups at an unequal risk of getting sick and dying from COVID-19, one of them including healthcare access and utilization. Ethnic minority groups are less likely to be uninsured compared to non-Hispanic white people, which limits them on what kind of care they receive. Other elements that add to the difficulty of accessing healthcare include having a means of transportation, childcare, ability to take work off, communication and language barriers, differences in beliefs between patient and provider, and current as well as historical discriminatory ways of thinking that have plagued our healthcare system. Question 2, is this population at a higher risk for non-communicable diseases? For this question, I could not find any solid research or evidence indicating that having a language barrier or limited English proficiency correlated with having certain non-communicable diseases. Question 3, is this population at higher risk for self-care deficits and or self-harm, unintentional or intentional? This population is at risk for unintentional self-harm. There is growing evidence that support the idea that language barriers may have a negative effect on the quality of care among limited English proficiency patients. The goal of one study aimed to examine the effects of language barrier on diverse populations, how much LEP contributes to medication comprehension, and the results of having a physician who speaks the same language. The results of the study found that LEP participants were much more likely than those proficient in English to be elderly, female, less educated, low income, and uninsured. Those who said they have a doctor that speaks their language were still more likely to report difficulties understanding their healthcare than those who are English proficient. Those whose physicians did not speak their language were significantly more at risk of having issues pertaining to understanding their medical situation, difficulties understanding medication labels, and an adverse reaction to medications. Possible solutions that can be implemented in order to increase patient safety starts with raising awareness for these populations and acknowledging that they are high-risk groups that need attention. Since the study found that having physicians who spoke different languages helped to decrease confusion among their patients, it is recommended that other healthcare professionals, such as nurses or pharmacists who are proficient in other languages, also be studied. Another possible recommendation is to make it a requirement for med students to speak a second language in order to be accepted into the program. However, training to learn a different language needs to be rigorous and thorough, eliminating any false fluency and avoiding communication errors. Having access to trained medical interpreters can also help to decrease communication errors and improve patients' perceived quality of care. Improved access and funding for professional interpreters will be key components in the process of improving healthcare for LEP populations. And then question number 4, is this population at higher risk of being harmed by others and or harming others? I found no solid evidence to support this.